Welcome to the Practicing with Dr. Nathan Goodyear podcast. I'm the medical director at Brio-Medical in Scottsdale, Arizona. I am both a conventionally trained and licensed medical doctor as well as a licensed medical homeopathic doctor. This podcast is your resource for a scientific-based discussion of all things cancer and beyond from a natural, holistic, and integrative perspective. It's time to teach the body how to heal. So here we go. Welcome back to another Practicing with Dr. Nathan Goodyear podcast. We're going back to bring somebody to the future here with us that we recorded a few podcasts with back in, I think it was late fall, early in the summertime. Dr. Jason Williams. He's got a clinic down in Cabo where he is actually revolutionizing how we approach cancer. And so if you want to check those podcasts out, I encourage you to go back and check those out. And we'll give him to give you his contact information at the end of this podcast. But how I want to start this out, and then we'll bring Dr. Williams in, is I want to really provide some context here. Kind of tee this up for Dr. Williams. One of my favorite movies, of course I'm a guy, but one of my favorite movies is that Russell Crowe movie, Master and Commander. And I know Dr. Williams likes to do some things with boats as well, but there's a famous quote in there that says, "Sir, might we press you for an antidote?" And what we're going to be doing here is Dr. Williams is going to be bringing forth, if you will, a few antidotes, a few case studies. And when you look at that word antidote, it's a really interesting word. It's a short narrative or an interesting, amusing. It's basically secret or private stories, things unpublished, things unknown to the general public. That's exactly what Dr. Williams is going to be bringing to you today on the Practicing with Dr. Nathan Goodyear podcast. Jason, man, it's good to see you.
Nathan, always good to see you. Gosh, we sat next to each other in medical school.
I know. So
it's amazing.
Yeah, it's, I think back to those times, and I think we look better today than we did then. Of course, don't you?
Probably do.
Yeah.
Probably do.
And in fact, it's going back so far, it's hard to remember what we even looked like. But, back then when we were in medical school, Jason, we were sitting there for 8 hours on end?
Oh, gosh, yeah. It was grueling, but, it was a good experience. Glad we did it, but glad we don't have to do it again.
Oh, isn't that true? You remember microbiology? Oh, my God.
Oh, yeah.
Gosh, yeah. They gave us the box of papers. I mean, it was just incredible. So, but anyways.
Yeah. It was, I had studied almost graduate level biochemistry before I even got to medical school. They blew through everything I knew in 2 weeks. So I was like, my gosh, the pace was so intense.
Oh yeah, it was nonstop, and you kind of look back on that. Honestly, right now, look back on it with fond memories. I think right after it was kind of PTSD, but
right.
Now with time, I think that started to heal a little bit. You and I were talking before we jumped on here, Jason, and when I talk to patients about fecal transplant, because that's the overarching theme of this podcast right here with you. Most people, when I talk to them about that, the look in their eyes is one of just absolute confusion and bewilderment. I can't imagine what's going through their head, but when I mention it to them, fecal transplant, they're clueless. Have you seen that when you've talked to patients?
Yeah, I think unfortunately the patients don't understand how important the gut microbiome is in relation to cancer. And, and this is, I think, one of the reasons we're seeing such a high incidence of cancer nowadays is because of the insult on the gut microbiome, disrupting the microbiome. And, what normally happens is the bacteria are in there and they actually are working symbiotically with your body. They're producing substances that end up doing things to your immune system, right? And help your immune system know to attack cancer or do other things. And they've even seen in mice, if you take gut microbiome from an older mouse and put it in a younger mouse, it makes the mouse behave younger. So you can transfer those type of factors. And it's really interesting all the effects of the gut microbiome, and now, I think it's really starting to come to the forefront, and people are starting to understand it. And I think they're also, they're obviously they're wondering, like, gosh, why are all these young people getting cancer nowadays? It discussed like the plastics, microplastics. Obviously people weren't wondering about vaccines and things like that. But the other thing is the gut microbiome, and look at like what a lot of people are eating. And so there are certain things that really insult the microbiome, like stevia, like Splenda. Those things actually kill the microbiome, and so they make you more predisposed to cancer. And there is a guy at the University of University of California, San Diego, named Rob Knight. He almost won the Nobel Prize last year for his work in the microbiome, and he has a test where he can look at your gut microbiome, and he will tell you what cancer you have. So
what you have, or what you're at risk for, or both?
Or both, yeah. But he will pretty much tell you, like, so he has a test. It's called Microbiome, and so it's looking at lung nodules. And if the person has a lung nodule, he looks at the microbiome. He'll tell you if that lung nodule is cancerous or not based on their microbiome.
Whoa!
Right. So that's exactly. So yeah. So if you can tell somebody has cancer based on their microbiome, then what does that tell you, the influence of the microbiome on cancer? And so to me, the majority of cancer patients have bad microbiomes. That's why they have cancer in the first place. I mean, there could be other issues, but that is certainly a foundation, a base. And so you have to fix that problem. And what I tell patients, if it's me, if I have cancer, the number one first thing I'm doing is trying to fix my microbiome and looking at something like a fecal transplant. And thankfully nowadays, though it is off-label, there is an FDA-approved fecal transplant called Rebyota. It is for C. difficile infection. So C. difficile obviously is a bacteria that people get when they take lots of antibiotics and kills off all your good bacteria, and then you get left with this pathogenic bacteria, and then you can treat it with more antibiotics like oral vancomycin, but a lot of times that doesn't get rid of it. The patients have diarrhea, and so how do you fix it? You can reintroduce new bacteria. I think that first was done maybe in the early 80s, right? And so, I think there's probably stuff going back further, but at least the stuff that I know going to the 80s. And so, the Rebyota, Ferring Pharmaceuticals, they developed this to treat C. difficile infection. The idea that if the patients have been treated with antibiotics, you could do this fecal transplant. Now, I have had meetings with the people at Ferring Pharmaceuticals. And just so you know, I have no financial interest in Ferring Pharmaceuticals. I wish I did, because they have a good product, but I don't. They're a private company, and but the thing is that they I don't know how they make this, because it's like, is it a pooled donor? How do they get good donors? I mean,
Right.
How are you going to get consistency with that? I mean, for the FDA to approve something, it needs to be fairly consistent. I mean, you give a product today, you give it in a year, it should be the same. Now, how are you going to do that with donors unless, now this is the only thing, and I'll tell you, I met with very high up people at Ferring Pharmaceuticals, and what I learned is that their formula is like Coca-Cola. They don't know. I mean, even the people high up in there don't know how they make it. And so what I can imagine they do is that they studied and analyzed and pulled some really nice microbiomes that were ideal, and then maybe sort of simulated, cultured it, and grew it, and pull from it. That's what I would think, that they had to do something like that, but I don't exactly know for sure.
So basically, their formula's crap.
That's right. It is.
It's crap on both sides. It is crap, but it's crap. I don't know what it is.
But it's very good crap. That's good crap. So yeah, I mean, so what do we do with patients? So we've been knowing that, gosh, since 2015, there were studies showing that the microbiome was hugely important for the response to immunotherapy. And so we knew there were certain key bacteria. Bifido brevi, Bifido longum, Akkermansia mucophilia, Clostridium butyricum, fecal bacterium prosnotzi. Those are some top bacteria. There's a bunch of others. So, looking at various, ones, and sometimes it's, you have you're lacking bacteria that you need. Sometimes you have certain bacteria that are there that you shouldn't have. So depending on the cancer, and some question, like for example, pancreatic cancer, the patient's microbiomes are bad. Should we actually wipe out their microbiome and repopulate them a new microbiome?
Well, that's an interesting concept, Jason, because you're talking about, everybody talks about, bone marrow transplants, right? And you've actually seen in the literature where they're actually referring to fecal transplant in very similar language as you would in terms of grafting. It's like it's a transplant, and so that's a very interesting concept that you just proposed there.
Yeah. I mean, this is sort of the type of thing that we've been doing with the patients, and so what for years, what do? We tried to give the patients the things that we knew helped their microbiome. So camu, which is a fruit from the Amazon rainforest. A lot of these good bacteria like polyphenols. So cranberry extract, things like that are all useful to help feed them, because one thing is having the bacteria, and the other is also what you feed them too. So you have the bacteria there, but then you also have to feed them appropriately, and then high fiber, fructooligosaccharides, inulin. Then there's this kiwi extract that they call Livox, which is helps increase fecal bacterium prosnotzi. These are all like interesting things that we were trying to do. And then there was a company that came out with a supplement or a probiotic that has Akkermansia. For years there was no way you couldn't take Akkermansia. If you either, for us, what we did, we would analyze the patient's microbiome. If the patients had Akkermansia, we said, okay, they could potentially respond. If they don't have Akkermansia, we're like, oh my gosh, they're probably not going to respond to immunotherapy. Their only option is the fecal transplant. So the only option we had was to try to get a donor and do it the old way. But then, this company called Pendulum Life came out with this product of Akkermansia. They have one of Clostridium. And so, and interesting, I think I sent you that study a few days ago talking about the young patients, or all these young people getting colorectal cancer.
Yeah.
And then they were saying they're finding a high amount of Akkermansia in the tumors.
Yeah.
But those are the ones that are the good responders, right? So it's sort of a response to the problem that's trying to get rid of it. And this is really interesting. And but we looked at the idea, like, let's test the patient's microbiome. Let's see if we can figure out who's good, who's bad, who needs the fecal transplant, who doesn't, who can fix themselves with supplementation. If some people can fix themselves with supplementation a little bit, I mean, that's certainly at least the easiest option. But a lot of people can't. And so, but what we found was when we did the testing, this is what I did. I took the patients, and the patients who tested well, I didn't give them Rebyota. The patients who tested poorly, I gave them Rebyota. The patients that I gave Rebyota responded really well. The patients I didn't give Rebyota to didn't respond as well, and so some of those patients I then gave Rebyota, and then they responded. So that made me understand that our testing was not useful. We couldn't tell whose microbiomes were good or not. And some the studies indicate that when they looked at like taking these super responders, these people who respond really, really well to immunotherapy, and do a fecal transplant to somebody who's a non-responder, and a decent number of those patients didn't start to respond. However, they found if they took people who had really good microbiomes but didn't have cancer, it was even better, because the super responders had cancer. So they had cancer for a reason, because their microbiomes weren't as good. Their microbiomes may be better than others, but they weren't as good because they had cancer.
Wow. Well, we've sat here for about 15 minutes now talking about gut microbiome. So I wanted to define a few terms here to kind of help people provide the context before we start jumping into the process of fecal transplant, and especially these anecdotes or case studies that you got here, which are pretty amazing. So first, I think it's understand there is a environment of bacteria, viruses, fungus that live with us and our cells. And the human microbiome is essentially the collective genomes and byproducts of all microorganisms. So this includes bacteria, viruses, and everything. And they inhabit the human body all over and are called the human microbiome. But now what Dr. Jason Williams has specifically been talking about quite readily is the gut microbiome. And what that is really the microbiome, the bacteria and viruses and other things, but here we're talking mostly about bacteria that are confined within the gut area there. And so when you were talking, Dr. Williams, about testing, is there a good test out there to help us to properly assess what that gut microbiome is like? Is there a good, reliable one clinically?
I'll be honest with you. I think, Nathan, unfortunately not. I mean, I think that you can look. So one, you could do a test like a commercially available like Viome. Patients can go online and just order that themselves. And then you could go and look and say, okay, do I have Akkermansia? Do I have Clostridium butyricum? Do I have these bacteria that we need? But I don't think that tells us the full answer. And there's one thing. So you've got the diversity, lots of different types of bacteria, but then also you got the numbers. So you could have lots of different types of bacteria, but maybe you only have just a few Akkermansia or a few Clostridium. That's there, but it's little. So,
Right.
But those people can be improved, and so, but yeah, it's difficult. I mean, I think that there's some patients that maybe are fixable, but I think some patients are not. And a lot of times what I'm finding is that we're giving patients immunotherapy. These immunotherapies are super expensive, and Rebyota is expensive, but it's a good investment. And so I kind of feel like, instead of throwing, good money after bad, maybe it's just better just to give them a Rebyota to try to fix them, so we're not messing around and wasting our time and say, well, let's do immunotherapy and it's not working. So we've, for the most part, started giving almost everybody Rebyota. And, there's, but otherwise, if you want to fix it, there was a recent study with, did you see the study from MD Anderson about navy beans?
I guess I did not see that one. What's
That's
that?
an interesting one. Yeah. Daily navy beans, improve the microbiome, improve survival in colorectal cancer patients.
Oh, wow.
And so, there's certain, food things that, so I went and bought a bunch of navy beans. I haven't started cooking them all yet. But
In the Navy.
I think I will. Obviously, I like red beans and rice, from Louisiana.
Oh, yeah.
As you know.
Oh, yeah.
So, like the New Orleans food, but there's a great study on navy beans with that, and so it's really, really interesting.
Well, we'll have to put that. We'll have to find that. Send me that study, Jason, because we'll have to put that in the show notes so that they can get access to that.
I'll send it to you. Yeah. It's a good one.
Well, it's really interesting. We're talking about the gut microbiome. Like you said, the literature is really starting to blossom there in terms of really giving us not just the what, but also the how, showing that the gut microbiome plays a significant response to cancer treatment, susceptibility to toxic side effects from treatment, and that both affects the immune system locally, but then also systemically, which is the mind-blowing, and thus affecting inflammation and even metabolism of the tumor. So really the concept of the gut microbiome, and these studies will be in the show notes. And when you look at a lot of this literature, it's really recent, right? And so what's been your experience when you talk to our colleagues, other doctors out there? Are they right on board with this, or do they know about it?
Most of them are like, what in the world are you talking about? Like, how does the microbiome have anything to do with anything? I mean, they don't understand it at all. It's like, it's surprising. I talk to patients at major centers, and like I said, I consulted with a patient who's getting her care at MD Anderson, and she's like, "Hey, I get all this of MD Anderson. Nobody's told me anything about the microbiome. Nobody's told me anything." I said, "Well, here's all their studies. These studies came from MD Anderson. The navy bean study came from MD Anderson. They have their own microbiome division."
Oops.
So they're doing all the research, but they're not actually getting it to the patients. They're not using it. I mean, really unfortunate. Yeah, I mean, so much of the things, I know we discussed before, like the issues like with acetaminophen, how it, negatively impacts immunotherapies. And, a lot of the doctors don't seem to understand this. It's like, should be, like a, 4-alarm fire here. We got to pull the thing and let's say, hey, all doctors need to know this.
And that's what's great about you, Jason, is you're such a pattern recognizer. I mean, a lot of docs, they're so analytical, which is great, but they're so sequential, right? They're so linear in their thinking. And I think, and this is where I think you and I have some commonality, is that, it's the bigger kind of pattern recognition, and then you're able to pick these pieces that most would not see and bring those and actually bring them into the clinical practice way ahead of the curve. And like you said, you're assimilating data that most don't even know about.
Right. Yeah. I think there was something at the water there in Shreveport that made us super smart.
There'd be a lot of people that probably say that's not the case, the water in Shreveport. But yeah, shout out to those people at LSU Health Science Center. So Shreveport, it was a great time. Definitely. One of the things that I've been looking at, Jason, and after this we'll jump into your first case study, is there was an article looking at pancreatic cancer. And they were actually talking about how the gut microbiome actually seeding pancreatic cancer. Yes. So, I mean, not just that there is a tumor microbiome. So people go, gut microbiome, I've never heard of that. But tumor microbiome, meaning we can now probably, there's literature talking about this, identify bacteria as much by the bacteria that's there as the histological or quote unquote, breast cancer and prostate cancer, but by the bacteria that's there. I mean, what's your thoughts on that? Because this is like quantum, it's on a whole nother level.
I mean, I think if you go back in the early 90s when they identified H. pylori for gastric cancer, and at first everybody's like, no, how does bacteria have anything to do with cancer? And then of course those doctors did that and they actually took it themselves and got it right, and then they get it themselves. And so the idea that bacteria can actually be the nidus cause of cancer, I think, is clearly evident. And in pancreas, the pancreas is a digestive organ that's connected to all of this, stuff as far as the intestines and everything else through the bile ducts. The bacteria transgress from those intestines into the pancreas. So the microbiome you have in your intestines also gets into the pancreas. And if that microbiome is bad, then it may promote cancer. And so it does seem to be that there are certain bacteria that get into the pancreas and are promoting that. Now then the question would be, well, so could you treat it with antibiotics? But it's not quite that simple. And once it's sort of formed, then it's going, right. The snowball is already rolling, and so you got to find another way to treat it. But you definitely need to fix the microbiome as a basic foundation.
Yeah, especially for the gastrointestinal cancers, right? I mean, esophageal all the way down, to the rectum. Do you think it has a place even outside of the gastrointestinal cancers?
It does, amazingly, yeah. So amazing, like lung cancer has a huge involvement with the gut microbiome. Breast cancer, recurrence, all that gut microbiome. I mean, it's actually most cancers really have an origin to the microbiome, or at least have some promotion from the microbiome. And it's extremely fascinating that that's the case, and that we definitely have been. I think standard of care has been ignoring this part of the whole thing. I mean, what are they doing? They're just looking at the cancer itself, treating it. What do? They give it a drug. They slam it with a drug.
Yep.
I mean, it's like if you're saying, hey, I'm I'm thirsty. Okay, not I'm gonna give you a bottle of water. I'm gonna give you a fire hose,
Yeah, yeah,
and
yeah.
just throw it on you. And so that's a problem. But yeah, I think that we need to be focused a lot more on that and getting all parts to try to get the best chance for these cancer patients to get good results.
Yeah, and that study was actually published in 2019, tumor microbiome diversity and composition influencing pancreatic cancer outcomes. So for me, somebody comes in with a diagnosis of pancreatic cancer, Jason, I'm aggressively moving on, the gut flora, fecal
Yeah.
transplant, et cetera. So this is I think a good spot to talk about your first case, because it's the 51-year-old with a pancreatic adenocarcinoma.
Yeah.
So
Yeah.
I think
It's
it would be really
amazing.
great here, because what we're going to do in the podcast is you actually send us those images, and that's perfect. We're going to pop those up so that when people are watching it on the video streaming services, they'll be able to see that.
Great.
So if you're listening to the podcast, go check out the video on YouTube or Rumble.
Good, yeah. So yeah, let me pull up because I've got several of the cases here, kind of all in the background, and let me see if I can find that specific
Yeah, because this
one.
is the gentleman with the pancreatic adenocarcinoma that was metastatic to the liver, which unfortunately is something we
Yeah,
see far too often.
yeah, and so you could see on that case where the patient, they've been getting some treatment and they were getting some response, but then they did Rebyota, and there's just sort of drastic shrinkage after Rebyota, just within a couple weeks. Both of the pancreatic lesions and of the liver metastasis in that patient.
Yeah, and you look
And
at
so,
the imaging there, Jason. I mean, you've got the arrows showing the drastic reduction in that. Now, when you did the Rebyota, were they only doing the Rebyota transplant here? So they had one transplant, or were they receiving other therapies?
so that patient, what happened was they were getting other therapies, but they weren't really responding well.
Okay.
They were just sort of stagnant.
Yeah.
And then the Rebyota kind of caused things to surge, and then they started getting a response.
Because
And so it
you had
was,
him on the, kind of the Gemzar, which is kind of the, one of the golden tickets, if
yeah,
you will, for pancreatic cancer. But then you had some other things on board, really trying to elicit an immune response, right?
yeah. So a lot of these patients are heavily pretreated, and they do Gemzar-Abraxane, durvalumab, and things like
Yeah.
that. So the the reality, in pancreatic cancer is that when you need immunotherapy for it, you need an agent that's called CD40.
Yeah.
CD40 is a real game changer in pancreatic cancer, but is not FDA approved yet, or I don't know when it'll be. But that that drug really makes a big difference. But yeah, that's you those patients. I mean, when they're doing Gemzar-Abraxane, usually they've done full Fox, full Fury. Now they've got the new one, the liposomal irinotecan,
Yeah.
that they're doing as well.
So basically, you were trying to elicit an immune response. Not much was happening. You come in with Rebyota, and you turn on the immune
Yeah.
response.
And then you see shrinkage in these patients. It's amazing. Like the patients are, progressing, or maybe they're just, stagnant. Maybe they're stable or slowly progressing. And then you give them Rebyota, and then all of a sudden now you start to see, shrinkage of their cancer. I'm not saying that Rebyota in by itself is enough to do it, but I think it's a big assist. And I think that when you're fighting cancer with chemo and everything else, if you don't have the microbiome working with you, then you're trying to paddle upstream. It's like it's really difficult, and so you need to fix that microbiome to help you.
It seems like the immune system, you're just not going to get the full immune response, or any immune response, without the gut microbiome optimized. And it's
Yeah,
interesting.
yeah,
It's interesting, Jason, because there was a recent study that came out, article that came out, excuse me, on ivermectin turning cold tumors hot. And I mean, the
right.
same thing could be applied right here, talking about, fecal transplant and the gut microbiome.
yeah, and and who knows? I wonder, is ivermectin's effect, could it even be on the microbiome? I mean, maybe
I was
ivermectin
setting you up for that because that's what I wonder. That's what I wonder is because we think about it. Oh, it's an antiparasitic. It's directly targeting cancer, and we think about our treatments. They're going after cancer, but maybe the effects that what we see from our treatments are actually in something that's completely out of our purview. But that in turn is what's happening to the cancer. It's just like what you do with your intratumoral therapies, right? You're getting systemic effects,
right.
but you're targeting one area. The effect is elsewhere, and so it's like that pattern. You're getting those pieces. You're hitting certain pieces, hitting the right pieces, the right codes, bringing it all together, and boom, you activate the body's defenses, and off it goes.
Yeah. Yeah, patients always ask me, like, hey, inject my tumor, is that gonna affect me elsewhere? It's like, well, if I give you a flu vaccine in your arm, it's not only your arm that's protected from the flu.
That's right. Well, I didn't get it in my arm. I got it in my leg. So that then brings us to, fecal transplant, which, like I said, that's still, I think, a word that's foreign, not only to patients, but to doctors. But I really think we're headed into the age of fecal transplantation as it relates to cancer. And it got me to thinking, I love history. And so it was late last night. My wife's out of town. And so I was staying up late, and I was, doing some weird reading last night. I was looking into the history of fecal transplantation. And it's interesting that they actually have documented quite a bit of history there. The first records of a fecal transplantation date back to fourth century China. I mean, let me tell you what, in China, they did some serious stuff way back when. Over and over again. You know what they called it? They called it yellow soup.
Really?
That's what I was like, oh my gosh. And they used it to treat diarrhea and food poisoning. But I was like, and I think that concept of yellow soup is probably what most people are thinking of when they think of fecal transplant, because they think we're talking about here. But you're not talking. Yeah. You're not talking about oral, are you?
No. There is an oral version, but we don't know how well that works, and it's much more expensive. And the Rebyota, the enema, is expensive, but it's less expensive than the pill. So yeah, we've been doing it through the enema.
Yeah, so, and it's just one time, but you repeat it sometimes, right?
Yeah, so generally one time could be enough, but as long as the patient needs to be making sure that they're maintaining their microbiome. If for any reason they need to be on antibiotics, they probably need another Rebyota. If they eat things like Splenda or stevia that kill your microbiome, then they probably need more Rebyota. Patients, like, I've treated them, and then they go and they start taking, and stevia and Splenda, this stuff is all over the place. You have to be careful, like, put it in toothpaste and supplements and stuff like that. And those are, a big insult to your microbiome. I think I saw that one packet of Splenda will disrupt your microbiome for 6 weeks. Wow. Stevia certainly is on an equal or greater level than Splenda. And I didn't know this, but so stevia got FDA approval, as generally regarded as safe, in 2008. However, in the 90s it was banned because they said it caused cancer. So stevia was discovered in 1899.
Oops. Jeez.
Yeah. So the thing is that everybody thinks, well, stevia comes from a plant.
Right.
So it's fine, but they don't remember that plants are poisonous. Lots of plants are poisonous because that some plants don't want you to eat them.
There's a novel concept. That's like me and cucumbers. They remind me every time I try to eat them.
Yeah. There's something you just know. Your body knows, like, hey, don't. For me, I never liked stevia, but they put it all over the place. Yeah, even like yesterday, I got something that had stevia in it. It's like I can't. It's hard to avoid it. Yeah. But I try to, and Splenda clearly, try to avoid. We don't want to go high sugars, obviously, but But people were eating sugars for hundreds of years and they weren't getting crazy cancers early on like we see now. I mean, later today, I've got a 21-year-old patient with pancreatic cancer. I mean, never see that in your life. Yeah.
It's interesting. So as I was continuing to go down the rabbit hole of, the history of fecal transplant, that breaks my heart with that 21-year-old. Oh my gosh.
Yeah.
That's not right, Jason. There was a tribe, the Bedouin tribes in Saudi Arabia, they actually would consume the stools of camels to treat dysentery. Really? And what's interesting about that, and there's an incredible, it'll be in the show notes, there's an incredible article. It presents a beautiful timeline, and I know that sounds really weird, of fecal transplantation. The German soldiers in World War II in North Africa did the same thing. They would eat the stool of the camels to treat dysentery. Now it's fecal transplant. We're talking about enema, but here they were recognizing the power of the microbiome in the gut, but through stool. But here it was interesting through the camels.
Yeah, yeah.
I don't recommend anybody out there to go out there and eat their camels, crap. So please don't do that. We're not promoting that, but it's just interesting that people recognize that way back.
Yeah. And I don't know why, like, it seems now though that, it kind of got lost, right? Like why did everybody sort of get away from it? And then, and now of course I think it's sort of reemerging.
And so I was going through the timeline, and there was talking about the curative power of stool. That was actually a book in 1697 that really, we ought to write a book, The Curative Power of Stool.
Yeah, it's interesting.
Yeah, your inner power of crap. I mean, that's where the immune system's at.
Yeah.
But then you're probably familiar with the mice studies where they actually were able to show sudden weight gain in mice through the transplantation of the microbiome. So actually showing that really kind of metabolism, weight gain, weight loss is almost something that is transmissible.
So this is the thing of the whole gut microbiome, and look, you can see this. It's not just cancer. It's heart disease. It's diabetes. It's all sorts of diseases. I mean, probably other neurological conditions as well, and things like that. And I can take a look, and like you can show me a CT scan of a person, and I can look what their liver looks like, and look at their vessels. I say, oh, this person has bad microbiome. I mean, I can see it on their CT scan.
Really?
So actually, one of the cases that we'll discuss, hers is a really interesting one. When you talk about fatty liver, the non-alcoholic steatosis, that's become a real problem, and that's because the microbiome is bad, and the bacteria not producing the right substances or producing things that are damaging to the liver, and it's all roots to the microbiome. And people are getting liver transplants over this nowadays.
Are you seeing? I've just been noticing. It seems like I'm seeing more people with brain mets. It's purely anecdotal, observational. I haven't looked into the literature to see if anybody's reporting that. Are you seeing more brain mets?
Well, so, I think one of the things that you're seeing is that there's a lot of these targeted drugs that they're using that seem to sort of protect the body, but drive things to the brain. I mean, and particularly, like HER2 positive breast cancers like to go to the brain.
Yeah.
But then, drugs that block HER2, well, at least Herceptin, Herceptin doesn't cross into the brain. Now, in HER2 potentially does, but so you'll kind of knock it out in the body, but then you're still leaving the brain as an option. So the cancer wants to survive. I mean, your body sees cancer as an organ. Mm-hmm. The cancer convinces your body that it needs to be there. Your body tries to protect it, so you're fighting against your own body trying to get rid of it. And so it's going to try to help it live wherever it can live. It's like, okay, if I can't live in the liver, or if I can't live in the lungs, let me go to the brain.
And the only reason why I asked that is because there's literature that talks about how the gut microbiome plays a role in contributing to neurodegenerative diseases, and it does that in part through breaking down the blood-brain barrier. And so I wonder if, I've not really found a lot of literature that says that, but if it's able to break down the blood-brain barrier, obviously a very protective barrier there, is that potentially going to exacerbate that potential risk? Like you said, compound it then with those therapies, just setting the stage for that process. I don't know, just a question. And then the last post they had of 2016 on the timeline, they actually referred to engraftment. So they actually started talking about it through the concept of transplantation, which brings us to again, ultimately this is a fecal transplantation therapy.
Right. Yeah. I mean, it's like I tell the patients, okay, it's like like you need a fecal transplant, and they're like, oh my gosh, like you're gonna operate and take out my colon and change it with somebody else's colon, or it sounds like all scary. I mean, in the end, you're saying this is an enema. It's an enema. I mean, you can go buy a Fleet's enema in a grocery store, right? So,
I actually had a patient. I actually thought a patient actually said, so you're going to hook up a tube to somebody's rectum and have a tube connected to my rectum? And I was like, okay, really, we need to explain this because people are coming up with some weird ideas.
Yeah, I know it gets confusing to the patient and scary. And the thing is that the thing that's happened with me is that as I started giving the patients Rebyota, the patients are come back and saying, "Gosh, I feel great. I feel really I feel so much better." And then their families are like, "Hey, we all want it too," and none of them have cancer, but they want it. They're like, "This works so well that." And I've thought about doing it. I mean, my wife is, she's like, hey, we should like do Rebyota, and it's a serious consideration. I haven't done it yet because I wonder like, well, is my microbiome, is it good or not? I don't know. Is mine better than Rebyota? Is Rebyota so good? But it seems to be pretty darn good, I guess, because you definitely see some good responses.
Well, it's a good place, I think, for that second case study that you mentioned. And I believe the one you were referencing, it was a 61-year-old lady with hormone receptor positive, HER2 negative breast cancer.
So this case is really amazing because, so when you look at her scan and you see that, see how dark her liver looks.
Yeah. You're talking there on slide A. Is that the slide A?
Yeah, exactly. So that is fatty infiltration of the liver. So when this lady contacted me, I said, I'm really worried about your cancer because your cancer is super advanced in the liver. I mean, you got a ton of disease, and I'm worried, but I'm also worried that structurally your liver is not good. Your liver is very fatty. And so you don't even have a lot of liver reserve. So your cancer is even worse than that because it's all in this fatty liver. And so I was like, my gosh, I mean, you're literally, if you didn't have cancer, you would need a liver transplant soon. Oh, wow. And so you can see on the case where you see all that darkness in the CT scan, that's the fat. The liver should not look like that, how it does on the left. Now, however, you can see afterwards, on the right, how the liver starts to look more structurally. You see that looks similar to the kidney.
Yeah.
And you can see the kidney there. And then as you go down, you see the PET CT scan. You can see all these lesions. She was riddled with lesions all through her liver. We went in, and in this case, we did Rebyota. She had improvement of her liver. Her liver was looking a lot better just a few weeks later. I mean, it's amazing how fast it was. And by the time we started treating, then you can see on this case where we stick our needle into a tumor. Yep. We do a pulse electrical field ablation to kill tumor, but in an immune stimulating way. And then we inject a combination of immunotherapies, into the tumor. And the patient had, amazing response and is going on. And ultimately, I think she'll be, end up being complete response. But that it was a combination of all those things. But if we didn't fix our microbiome, we would have just really been, up against it, because there's no way to fix all these problems without doing that.
So, I mean, we're not talking about, people that just have colorectal cancer. We're talking about people that have, stage 4 cancer. I mean, it has spread all over the
Yeah.
place. So we're not talking about
this
easy choices here,
No, no, these are all, mostly, for me, the majority, I don't usually take on like very much early stage patients. I take on more advanced, because, early stage patients have other options, but clearly early stage patients should probably be doing these type of things as well to prevent themselves from getting late stage. But yeah, these are advanced, and that was a breast cancer. And so you can see the big change and big response. I mean, it was really, really amazing. I mean, this lady otherwise would not be alive.
Yeah. We talked about that study looking at, it actually was published, I think, February 1st, 2024, looking at the gut microbiome in the people with colorectal cancer under the age of 50 and those over the age of 50, and really evaluating the microbiome there. And of course, you talked about the potential patient that you're talking to that's 21 with pancreatic cancer, and she's going to be in good hands with you. So here's my question. Right now, the way conventional oncology tackles colorectal cancer, it's early assessment, right? Early screening. What are we going to start doing? Colorectal screening at age 25? Is everyone going to start getting, colonoscopes at 25? It seems to me, and you kind of touched on this with the gut microbiome, might we change our focus and start assessing the gut microbiomes early, and then go, okay, who's at risk here, and then introduce strategies, maybe even fecal transplantation at that point, to remedy the issue?
That's definitely going to be the more proactive way to handle this, to try to fix the problem up front instead of dealing with it later. So yeah. But yeah, I think we're going to have to start screening patients earlier, and patients are going to have to change their habits. I mean, I just wonder, is it because like these younger kids nowadays, are they drinking a lot of these energy drinks, have like sucralose and stevia and those things? I mean, is that what's, messing up their microbiome? Because, other parts of the diet, been around for a while. People have been eating McDonald's for a while. People have been doing all this other stuff for a while, but, it's just this, a rapid sudden surge. And so, you kind of have to look at sort of the potential culprits for it. But yeah, I think at least now people probably need, a yearly Cologuard with the, looking for DNA in the stool.
Yeah. Yeah.
And obviously you have like Grail Gallery. Is another test.
Yeah, there's a lot of great. That's what's super exciting, is there's a lot of great tests that are advancing the ability to detect early, obviously, disease, but really we want to identify it before it's there. Those that are high risk, and I wonder if there is clear advantages to AI, right? And I wonder if AI can help us in this assessment, and then be able to identify these people and target them for restoration. Because if the gut microbiome can seed pancreatic cancer, why can't the counter be true?
Yeah, I think you're right. We don't. Obviously the microbiome is so complex. There's so many bacteria that I do think that we have to use an analysis when using AI to try to predict who are the people at risk. And I think that's kind of a little bit of the direction that Rob Knight is going there at UC San Diego. I think this company's going that direction. And on our side, we have something we call Cancer Care AI, which basically is an AI system that combines looking at the gut microbiome, looking at the tumor DNA, looking at cytokine panel, looking at radiomics. Like, for example, you can look at the texture of the tumors, and you can know this tumor is infiltrated with T cells. This one's not. This one has macrophages. It's not just, there's a tumor there. A tumor measures, 6 centimeters. Though it's actually heterogeneous inside of it. Like if you're going to do ablation on a tumor, you don't go target, I mean, particularly on advanced cancer, people have the mistake, they think you go in there and try to ablate the entire tumor. That, if an advanced cancer patient, that's a mistake.
Yeah, I agree.
You don't do that.
I agree.
You ablate part of the tumor, and what you do is you identify the targetable areas, like on a PET scan, on CT. You say, this part of the tumor is controlling it. This area is like the command center for the cancer. And if I knock that out and inject immunotherapy there, that's going to work. And that's why we're not seeing as good of results with like things like standard ablation, because what do? Standard, you go to a standard center, MD Anderson, Sloan Kettering, John Hopkins, whoever, and what do? They stick a needle in there, just anywhere in the tumor, try to start killing it. They're not very precise. We're trying to educate these people, educate the doctors that this is not how you do it, and they just have not caught on. They don't, most of the time now they don't believe it, but eventually they will. Right now they think we're crazy. In the future, then they'll say, okay, we were geniuses.
Yeah, well, Galileo, they tried to kill him. Thankfully, I don't think that's happened to you or I, because he had the audacity to suggest that everything rotated around the sun. So and you're actually saying no, we need to target the tumor with our interventional therapies, but we need to bring the gut microbiome and fecal transplantation in with that, because that optimizes the immune system. So, is there any therapy that this can't be used with? That here I'm talking about fecal transplantation, chemo, radiation, surgery. How does that work in your practice?
To me, it's a thing, and I would tell patients, if I'm diagnosed with cancer, if you tell me today, and if I get a scan and it looks like there's something that looks like cancer, tomorrow I'm doing Rebyota. That's the first thing I'm doing. I think that's like, that's the basic foundation that you have to do. And so now certainly we know that chemo and other things may impact the microbiome,
right?
But at least you go ahead and start trying to fix it. I mean, you might not make it perfect, but you're going to make it better. And I think what there's not. I think it was really everything, and I know that maybe that's bold. And I think maybe the people with the Free Pharmaceuticals, I mean, we've discussed doing further clinical trials and things like that, so we can demonstrate this. And I think we'll see this in the future. But it is a drug that's there. It's available. It's available off label. The unfortunate side, it's somewhat expensive. I mean, it's a costly thing, and so. But I'll be honest with you, it's well worth it.
It's
worth the investment.
In the whole scheme of things, it's really, I mean, money is money, right? We have to be honest. But I mean, in the whole scheme of things, for the cost, which I'm not going to mention here, it's really not that expensive for the impact that it can have. Not at all.
It is. No, because think of it. I mean, it is, it's cheaper than a single dose of Yervoy for sure. It's, comparable to a single dose of Keytruda, and yet it's arguably way better because it's in there and it lasts and keeps working. And so, this to me, I mean, I think Rebyota, what they have, this will be a bigger blockbuster than Keytruda. I mean, Keytruda is one of the biggest drugs probably in the history, right? I think it's like $25 billion a year or something now, projected to be maybe $50 billion or something.
Sounds like there needs to be some clinical studies ongoing with this. That's what it sounds like.
Yeah.
What about somebody, and if ever you do that, I'd love to be a part of that, because I'm involved with the new multi-center observational study with ivermectin. That one, we just did a soft announcement on that. So it'd be interesting to see checking the gut microbiome of those individuals and the responders there.
Let's do it, because Free Pharmaceuticals is game for this. I mean, I've had the discussion. They were shocked. I mean, first thing is that they were like, I met with them. They were like, well, they said, who are these? Which group of doctors is this that's buying all this Rebyota? It's like this one guy. He's buying like a ton of it. He buys more than the entire United States, I believe. And so they're like, well, this stuff is not really flying off the shelves. I mean, they're not even using it in C. diff very often. I mean, they're just, it's just not used appropriately. And I said, well, look, this thing looks like it works really well for cancer. It needs that. It should have been developed for cancer. You guys just didn't know it.
Right.
But that's where it's going.
But that's kind of the history and pattern of medicine in the past is something's discovered over here and it finds its true innovation and use here.
Yeah, just like Viagra, blood pressure, being blood pressure medicine and ended up being obviously for erectile dysfunction.
Yeah, he says, yeah, my blood pressure is okay, but oh my gosh, wow. It's like, okay, we got something here, guys. What about somebody, you talked about giving Rebyota or fecal transplant with Rebyota before treatment. What about if somebody's hearing this and they're right in the middle of treatment? Can they go ahead and do that, or do they need to take a break, or what?
I don't think so. No, I think to me, if you have cancer, you're getting treatment. The first and fastest thing you should do is Rebyota.
Yeah, I don't disagree with that at all. So because I really think that, gosh, disease and the healing capacity, it really begins there, because when you look at nutrition and what we eat, its impact. Everybody thinks about calories. Everybody thinks about sugar, and they think about insulin and inflammation, and all rightly so. But the impact is, I think, on the gut microbiome is huge. It's just enormous. Yeah. Now the last case study. Go ahead.
I was just gonna say, your body has a need for various things. Obviously nobody thinks that's odd that you need, vitamin D or vitamin B's or A or anything like that. But it's like, but you really, your body needs a little bit of this, a little bit of that, a little bit of all these things, and the gut microbiome needs its stuff to be fed and for the bacteria to behave, appropriately and do the things. The bacteria, and we know certain things, and we know that sodium butyrate, we know that that inosine, that those type of things are things that are made by the bacteria that are helpful to the immune system. So arguably, could you take a supplement that just replaces what the microbiome does? Maybe. I don't know if we know that for sure or not. But I guess that's a consideration. But the microbiome, your biggest part of your immune system is along the lining of the intestines.
Yeah.
And that's where that interaction occurs. And so the immune system, we've evolved to have that, and to have the immune cells, getting those substances from the bacteria. And if you kill them off with certain foods or artificial sweeteners or stevia or things like that, then your immune system is not getting the stuff it needs. It doesn't behave the way it should. Yeah,
we'll get to that last case study here in just a moment. It's the melanoma patient. But if the gut microbiome in a fecal transplant can basically show transmissibility of obesity in the mice model in that study, could we almost say that cancer in a way is transmissible? And maybe it's not transmissible from gut microbiome to gut microbiome, but what about inheritance? So in this effect of talking about genetic inheritance, epigenetic inheritance, etc., the microbiome that we're inheriting from our patients, that's what I'm talking about. Not from person to person, but from parent to child. Are we passing on microbiomes, Jason, that are setting this stage?
That is a very good point, Nathan. I mean, that's something that I don't think many people would ever think about. But clearly we know there are certain genes that BRCA and things like that, and P53 mutations and things like that that may give a person predisposed to cancer. But then also, the microbiome, because of course tends to be that the microbiome is what you get from your parents and being around them. It may not be exactly, but whoever you live in close contact with, you're most likely to have a similar microbiome with that, particularly if you're eating the same things and things like that. And so it's quite possible, and that's contributing as well, and why you'll see these more familial connections to these cancers.
Yeah, they may be thinking of the wrong inheritance.
Exactly. It's definitely got to be a component as well. I mean, all these things. The thing with cancer is that it's a little bit here, a little bit there, but it all adds up, and then you get enough that sort of finally just tips it over, and you get cancer. And so every little thing that you can stop is going to really help impact and reduce your chances.
So let's jump onto your last case study. And understand, if you're just listening to this podcast, go over to the video formats on YouTube, Rumble, because this is where you can actually see the imaging and hear and see the evidence of what we're talking about as you listen to it. So this was the 36-year-old male with melanoma.
Yeah. So this guy, and he came from MD Anderson. He lived in Houston. He lives in Houston. And he had been heavily pre-treated. I mean, he had everything. They gave him all the different main options that you would normally do with melanoma. I mean, even beyond. I mean, to go with a double and then a triple immunotherapy combination, because with Yervoy, not Duolag, you're getting a PD-1 and a LAG-3 inhibitor, both combined with a CTLA-4 inhibitor being Yervoy. And so that, that's heavy duty. They don't normally do that with people. Most people have never gotten to where this guy had gotten, and yet he continued to progress. And so you can see on the first case is like all these liver lesions. He had lesions elsewhere, lungs and other places, but this is kind of demonstrate that. But the thing that amazed me was that I told him, I was like, yeah, you should do Rebyota, and then he's going to come to me. And I sort of forgot, that well, I mean, I knew he was going to do Rebyota, but I was thinking that he had started a new therapy. So he comes to me, and we're going to do the procedure. So we do a scan. Now, there's a difference in these scans because the first one has contrast and the second one doesn't. So you don't see the tumors quite as well, but you can still see the vagueness of the tumor that's on the left side of the screen, on the edge, and then like over where near the spine. So there's an adrenal lesion,
Yep.
and then you see these other little spots that you don't really see very well anymore. And so we scan him when I'm going to do his procedure. I was like, so many of his tumors went away. And I said, whatever therapy that they switched him to must really be working. And so I said, then actually my assistant who's with me said, hey, but he's not doing anything. And I was like, what? I was like, I thought maybe they put him on something different or switched him on different drug or something. And they're like, no, he's off therapy. And I'm like, oh my gosh. I was like, this is with Rebyota alone. And I couldn't believe it. I was shocked.
So basically, he came to you, and he had been on the standard of care, conventional standard of care, and basically had all these metastases. You thought he was getting switched to something different. Did the Rebyota? Yeah. He didn't do anything different, just the Rebyota, and these results were as a result of that.
That's right. Yeah, and so that was sort of, I would say, the aha moment for me. I was like, oh my gosh, I knew. Now I've seen occasionally, so over years, at least since 2015, we would have people do maybe a fecal transplant. They would do, family donors, or there's, some clinics in other countries like Canada or something like that have some that'll do it. But I saw some improvement. But I never saw anything like this with Rebyota. I mean, I just have to say, again, I have no financial interest in Rebyota. I wish I did. And they seem to have something special, something that's better than all the other, because that's what people ask. They say, well, if fecal transplants can I just, can I do it for my husband? Can I do it for my sister? Can I do it for my kids? Maybe that might work. But all I know is that Rebyota seems to be superior.
Yeah. Well, Jason, thank you so much for taking time out of your schedule on this Friday afternoon and your consults. Thank you so much, friend. Going back years, it's so funny how we have circled back around again in this arena of cancer. And again, thank you for taking time out of it, talking about this, this really pungent topic, right? Fecal transplantation. Yeah. So where can the listeners or viewers, where can they find you? And one thing I failed to mention, you're a published author, right?
Yeah, so I have a book. It's called Immunotherapy Revolution. I need to write a newer one and get things updated, but that book was ahead of its time, and now it's kind of coming along. It has a chapter on the microbiome. I mean, I wrote that I started writing that book in 2015. It actually came out in 19, and but has a chapter on the microbiome, has a chapter on off-label drugs, has a chapter on supplements. There's certainly been some new developments in off-label drugs that have updated. So yeah, the immunotherapy revolution. They can see my book on there, and obviously, and then we're Williams Cancer Institute. We have an office. Our main U.S. office is Beverly Hills. We have an office in Miami, and we have our hospital in Cabo that we work with. We're now developing our own floor. We're really getting advanced, bringing in a lot of new equipment and stuff. We're probably doing things with robots and AI. We got these new we're buying these new virtual reality things where we can look and we can see all the stuff inside the patient while we're looking at the patient, and it has their scans, and we can merge all their scans. It's really futuristic. It's some amazing stuff.
So Star Trek, pretty soon you're just going to kind of scan them and click a button, and I guess they'll be well, huh?
Yeah, we're working on those type of things, with the whole body pulse field and stuff like that.
You showed me pictures of that, man. I'm super excited about that. Now you're going to have to do that in Mexico City, you said, right?
We will do that initially in Mexico City. So we have some clinical trials. So we run a lot of our clinical trials right now in Mexico City. Unfortunately, several of our trials are all closed. Our breast cancer trial closed, our prostate closed. We will present our data at the AACR, American Association of Cancer Research in San Diego on April 7th. It will be a pretty big deal. It will be our initial prostate data that we have. And so, I won't spoil it.
Yeah, so, April 7th. I said, mark that down, because I think I'm going to have to come out and see you, friend.
You should come. It's gonna be big, and so there's a lot of interesting stuff going on. So much. There's just a really exciting time in cancer.
Well, it's super excited to again know you as a friend, know you as a colleague, and you're always accessible. You're always available. Thank you again. Thank you for joining us with Dr. Jason Williams again. A treat for you. And again, we interviewed him back when we were in Cabo, and he talked about his book. We talked through other cases and talked about how he was innovating in the immune system then, and guess what? He continues to innovate in the immune system now. So we'll be bringing you an update, I think, on that April 7th announcement. So look for that coming at you very soon. Thank you for following the Practicing with Dr. Nathan Goodyear podcast. Lots of downloads. So thank you very much. I encourage you to download, sign up for the podcast, and share it for those. Share it to those who have cancer or you think may need to know about this information. Family, loved ones, whoever may need to hear about the gut microbiome, which, by the way, just a little clue, it's everybody. Share this with everybody. Also, you can check us out over at the drgoodyear.com website and at Brio-Medical, where I am the medical director. And if you follow us on social media, guess what? We're everywhere. So check us out there as well. It's important to understand that there's always hope. And discussions like this with innovators around the world, here, one right in Beverly Hills and in Cabo, they provide hope. And remember, that word hope means confidence in tomorrow. And people like Dr. Jason Williams and the innovation and the thinking that they're bringing to the world of cancer gives me hope that tomorrow is going to be one for healing. So remember, Dr. Goodyear from Practicing with Dr. Nathan Goodyear podcast, hope it forward.